Hello, class, and welcome back as we continue on exploring the fascinating world of abnormal psychology and the differences between mental health and mental illness. Now, next, we will focus on the history of diagnosing mental illness. And we will explore how the Diagnostic and Statistical Manual, the Bible of figuring out what disorder it is, was developed, and how it sets specific criteria for diagnosing a person with a specific mental illness. And we will also look at a detailed example of what's going on with this in a diagnosis. So the history of diagnosing mental disorders is a long and complex one, dating back to ancient times where mental disorders were often attributed to natural causes, such as possession by evil spirits or punishment from the gods. Some saw that there was a need to drill holes in your brain or to let out certain fluids from your body in order to find balance. Now, as medical knowledge progressed, however, mental disorders became to be seen as diseases of the brain or the nervous system. And in the 19th century, psychiatry emerged as a medical specialty. And the first diagnostic classification of mental disorders was developed at this time. And within this classification system was what is known as the Statistical Manual for the Use of Institutions for the Insane. And this was something that was published in 1917 by the American Medico-Psychological Association, which was a bit of a precursor to what we now know as the American Psychiatric Association. And this manual included a list of mental disorders and provided guidelines for their diagnosis and treatment. Now, over the next several decades, various diagnostic systems were developed, including the International Classification of Diseases, the ICD, which was first published by the World Health Organization, the WHO, in 1949. The ICD, the International Classification of Diseases, included a section on mental disorders, and subsequent editions continued to expand and refine the section. Now, from that time, about 1920 through to 1950, the view of mental disorders was very much focused and based upon theoretical backgrounds to a large extent, because there was a limited amount of medical knowledge and research on mental disorders. And so a lot of it was tied into Freudian ideas, and Freud's psychoanalytic and psychodynamic perspectives really dominated the understanding of mental disorders. But in the 1950s and 60s, research really started to grow, as well as a growing recognition for the need for a standardized diagnostic system for mental disorders, particularly in North America. So in 1952, there was the first edition of the DSM, which is the American Psychiatric Association's diagnostic guidelines. And this manual included a list of mental disorders and provided guidelines for their diagnosis and treatment. Now, the first few versions of this were still very heavily laden upon, were not really all that objective. Now, when it came to the third edition, the second and third edition, you had different axes, different dimensions of a person's functioning being recognized up until the fourth version. And then with the DSM-5, which was published in 2013, that multi-axial system was dropped. But instead, you still have the very clear, objective criteria for making a diagnosis. So in the DSM-5, we have over 300 diagnostic categories, each with specific criteria for making a diagnosis. So the DSM-5 sets specific criteria for diagnosing a person with a specific mental illness. For example, let's take major depression, for example, or major depressive disorder is what it's called. To be diagnosed, a person would need to have experienced 5 or more of the following symptoms during the same 2-week period, or at least one of the and at least one of the symptoms must be either depressed mood or loss of interest or pleasure in nearly all activities, something known as anhedonia. So some of the symptoms that need to be in place, you need to have 5 or more of these. First off, depressed mood most of the day, nearly every day. Secondly, diminished interest or pleasure in nearly all activities, most of the day, nearly every day. Third one, significant weight loss when not dying, or weight gain, or decrease or increase in appetite nearly every day. Fourth, insomnia or hypersomnia nearly every day. Fifth, psychomotor agitation or retardation nearly every day. Sixth, fatigue or loss of energy nearly every day. Seventh, feelings of worthlessness or excessive or inappropriate guilt nearly every day. Eighth, diminished ability to think or concentrate or indecisiveness nearly every day. And ninth, recurrent thoughts of death, recurrent suicidal ideation without a specific plan, or a suicide attempt or a specific plan for committing suicide. Now, in addition to meeting these criteria, a person's symptoms must also cause some significant distress or impairment in their functioning in social circles, in their occupation, or in other areas of functioning. So, in essence, the history of diagnosis of mental disorders has progressed significantly over the years. And now we have the DSM-5, which is a standardized system for diagnosis. Now, as a social and community service worker, you would not be diagnosing anybody, but it's important to understand the role of the DSM and to be able to consult the DSM from time to time to gain ideas of how someone might be functioning, and to maybe possibly make referrals to an appropriate professional for their care. So that's something to always be mindful of. And of course, as we go through the larger program, you will learn more about this. Then we come finally, and I want to focus now on a few common mental disorders that you may have heard of. And the first I want to focus on is autism and Asperger's. Now, these are 2 related developmental disorders that are now classified as part of autism spectrum disorder. So we'll discuss the historical differences between autism and Asperger's and their current classification, as well as provide statistics on the prevalence, the prognosis, and treatment options. So autism and Asperger's were historically different conditions, with autism first described in the early 20th century and Asperger's described in the 1940s. Now, autism was originally used to describe a range of developmental disorders characterized by social and communication difficulties, preoccupation with repetitive behaviors, and restricted interests. Asperger's, on the other hand, was considered a separate condition and was characterized by those same social and communication difficulties, but without the language delays that are typically seen in autism. And also in autism, there would tend to be a lack of interest in engaging with other people, whereas Asperger's people actually typically do want to engage, but they have trouble with it. Now, in 2013, when the American Psychiatric Association revived their diagnostic criteria for autism and Asperger's, they combined these 2 under an umbrella term known as autism spectrum disorder. So with the DSM-4, these were separate. With the DSM-5, the Diagnostic and Statistical Manual version 5, they are now under autism spectrum disorder. And the reason for this change was to better reflect the overlapping symptoms and the range of severity that we see within individuals with this condition. So autism spectrum disorder, what it is called now, is now defined as a neurodevelopmental disorder characterized by persistent deficits in social communication and social interaction across multiple contexts, as well as restricted, repetitive patterns of behavior, restricted and repetitive interests and activities. And these symptoms must be present in the early developmental period and cause significant impairment in social, occupational, and other areas of functioning. Now, the prevalence of autism spectrum disorder has been increasing over the years, with the latest estimate by the Centers for Disease Control and Prevention in the United States, the CDC, indicating that they think that 1 in 54 children in the United States are now diagnosed with autism spectrum disorder, with boys being 4 times as likely as girls to be diagnosed with ASD. Now, the exact cause of ASD isn't known. There's a lot of common theories out there, but we don't really know. It's believed, though, to be a combination of genetic and environmental factors. And so the prognosis for individuals with ASD really varies depending upon the severity of the symptoms, as well as the availability of early interventions. And early intervention does seem to help, because if there isn't that early help, then people may need some significant support later on in life. But some individuals with some early intervention can lead really independent lives with minimum support throughout their life. So early intervention does seem to be fairly important. So the treatment for autism spectrum disorder tends to be a multidisciplinary approach, including things like some behavioral therapy, working with speech and language, helping with occupational therapy, and perhaps medications that can help in some cases. So in essence, autism and Asperger's were historically separate, but are now classified as part of ASD, autism spectrum disorder. Now, let's focus on attention deficit hyperactivity disorder, ADHD, and we will discuss its prevalence, its etiology, its biology, its treatment, and how it is diagnosed. So ADHD is, again, another neurodevelopmental disorder characterized by symptoms of inattention, hyperactivity, and impulsivity. So it's a condition that can affect both children and adults and can significantly impact academic, social, and occupational functioning. So let's look at the prevalence of ADHD. ADHD varies depending upon the population being studied and the diagnostic criteria used, but the CDC, the Center for Disease Control, estimates the prevalence of ADHD for children ages 4 to 17 at about 9.4%, with boys being much more likely to be diagnosed with ADHD than girls, with the ratio at probably about 3 to 1. And with adults, the estimated prevalence of ADHD is about to sit around 4 to 5%. Now, the exact cause of ADHD is unknown, but it's believed to be a combination of genetic and environmental factors like most disorders. And there does seem to be an alteration in the neurotransmitter system. Things like dopamine and norepinephrine seem to play a role in regulating attention and behavior. Now, this might be because of prenatal exposure to toxins or premature birth, low birth weight. All of these have been associated with increased risk of ADHD, but no clear cause. As far as the biology goes, brain imaging studies have identified that there does seem to be some structural and functional differences in the prefrontal cortex, which would be expected because that's an area of the brain responsible for impulse control, for focusing, for executive function. And individuals with ADHD may also have a difference in the basal ganglia, which is a group of structures in the brain that regulate movement and reward. And again, because dopamine seems to be involved and the basal ganglia is a dopaminergic system, we would expect to see some differences there. Now, as far as a diagnosis of ADHD, it's typical to be made by a physician and based upon some very specific symptoms, including inattention, hyperactivity, impulsivity, and the presence of at least two of those in more across settings, and where it makes significant impact upon a person's social functioning or occupational functioning or academic functioning. Now, as far as the treatment goes, there are some behavioral treatments, but normally it is done in combination with medications. And a lot of the medications are stimulants that work on increasing levels of dopamine and norepinephrine within the brain in order to help the person to function better. Now, overall, both autism and ADHD are neurodevelopmental disorders, which tie in with a larger frame of mental disorders. Now, the exact cause of each of these disorders that we've discussed is not clear, but we have developed some strategies for treatment, for care, for intervention to improve the lives of people, and this sometimes includes medications as well as behavioral therapies. So overall, mental health refers to a state of well-being in which each individual is able to cope with the normal stresses of life, to work productively, and to contribute to their community. So it involves emotional, psychological, and social well-being, and mental health can influence others, but it can also be influenced by a variety of factors. So things like our genetics and our environment and life experiences. And so, on the other hand, mental illness can also be affected by those things. And what mental illness is a condition that significantly impairs an individual's ability to function in some area of life, like work or school or home or relationships. It can affect their mood, their behavior, or their cognitive processes. And again, a variety of factors can be involved within this. As far as diagnosing someone, we use the criteria of the DSM-5 to make a diagnosis, and that is what mental health professionals do, is make a diagnosis through this standardized language, and across these classification areas we are then able to research and establish what are good therapeutic interventions, what works and what doesn't work. And that helps everyone. Specifically, when we look at disorders, the kinds of disorders we looked at this week are things like autism spectrum disorder and attention deficit hyperactivity disorder. As we've mentioned, ADHD is a neurodevelopmental disorder that involves symptoms of inattention, hyperactivity, and impulsivity. Boys are more likely to have ADHD than girls. Same with autism spectrum disorder. Boys are more likely to have it than girls. Autism spectrum disorder, a combination of what used to be autism and the Asperger's disorders were combined into the spectrum, recognizing that there is a wide range of severity of these disorders and some overlap of the symptoms. So, some people suffering from autism spectrum disorder will have difficulty throughout their life, and some are able to function quite well with a little bit of support. In conclusion, I want to kind of leave you with this, that whether a person struggles with mental illness or not, they are still people. They are still people of value, and they deserve our respect and our care. Remembering that mental health disorders cause a significant amount of distress for the person experiencing them, and isn't just something that's uncomfortable for those around the person. And so, in so doing, I hope we can provide care and support for those individuals in social contexts and in community services. And remember that seeking help and support for mental health concerns is a sign of strength and can lead to a better quality of life. I hope you enjoyed this lecture. You take care, and I'll see you in our next lecture. Goodbye.